Well, thank you very much. An honor to be here to present to this group. Certainly nice to see a large audience still here on Saturday afternoon when you're competing with beautiful beach weather and many things going on, so thank you. What I'm going to talk about is how we can handle situations a little bit out of the ordinary. I should tell you I've had the honor of serving as professor and chair of the department at the College of Dental Medicine, South Carolina. With that, we have 2 education grants, one from Nobel BioCare, one from Zimmer Dental. I serve as a consultant for Zimmer Dental. I'm on the Speakers Bureau, but I have no financial interest in any materials or anything that you will see presented here this afternoon. And so this entire program has been dedicated to the treatment of patients, taking care of our patients. What can we do? And so any one of these patients may walk into your office next week when you get back. And so we ask ourselves, what do these patients have in common? What is it that we do? And so I think we can identify some things here. Certainly, they all need dental treatment. In today's world, everybody wants everything faster, so they would like to have something immediate if possible. Nobody walks into our very fine surgeon's office, nobody walks in and says, I've been searching for someone to do some surgery on me. And so they're trying to avoid surgery. We, as the providers, we want something predictable. When we do a procedure, we want to be sure that it's going to work. And we're looking at a scientifically based approach to it. And so those are issues we'll try to address in our presentation. And so I'm a restorative dentist. I don't do any surgery. And so when I see problems, I'm constantly looking at what are my prosthetic options? How can I handle this? And so I think we can look at what we have today. We have outstanding materials. We still do metal ceramic restorations. We now have zirconia, pure zirconia, or zirconia with bonded feldspathic. We have the fixed hybrid restoration, representing the categories of fixed. Then we have the removable overdenture of some sort. So we have a lot of options to treat those patients. Now, what we're going to focus on, the mandibular hybrid prosthesis, is what this presentation is about. And so what is a hybrid prosthesis? Certainly nothing new, something we've been doing since the early 80s. And when we started doing the endosseous implants, our patients that couldn't wear those mandibular dentures, we could place implants and we could give them something fixed. And so the definition is a denture with a denture tooth, acrylic design with some sort of metal substructure, either a milled bar or a cast metal substructure. And so will these work? As I said, this was a patient I treated in the mid-'80s, certainly having to replace the teeth in the acrylic numerous times, but about 25 years later, those implants are still in there. The bone looks good. The prosthesis is working. The patient's happy. We provide the routine maintenance to take care of it. So will this work? Yes, it will, and we have plenty of evidence of that. And so now we would like to look at, okay, if I have these options, how and why should I choose one over another? And so taking information from Carl Misch in his Dental Implant Prosthetics book, we can kind of do a little comparison. The hybrid prosthesis, by virtue of the way it's made, costs less. But there's one of the major components here is that vertical space that we have, the space between the opposing occlusion and the crest of the bone. The hybrid prosthesis will require 14, 15 millimeters of space to be able to get the metal substructure and the resin in there, because that resin depends on volume for strength. And also, it's easy to repair. We can do an easy repair on a hybrid prosthesis. And so in the mandible then, we look at anterior to the mental foramen, 4 or 5 implants. I have seen them with 6 implants. It functions as a fixed bridge. It's screw retained. It has a cantilever. Our goal is to have it extend to the first molar. Arch form is important. And the patient who's a long-term denture wearer may not get the lip support once we take the flanges away, but most patients do well with it. And this would be a classic indication for it. Now, the way we would handle this in the past was, it was a classic design. take the failing teeth out, place the implants, 2-stage surgery, 4 to 6 months, uncover, final impression, aesthetic try-in, metal try-in, getting our records, and then coming back and doing the process and delivery, taking 6 to 9 months to be able to get that done. But we certainly got an excellent result. Our patients, those denture wearers, I've never had a patient that wasn't very happy once we converted them to a denture to something fixed, because it just worked so well for them. And so, but these have a cantilever. Cantilevers are very efficient tools, and cantilevers put stress on the implants. It will stress the prosthesis itself. So one of the things we would like to do is maybe get rid of that cantilever. And so how do we know how far we can cantilever? Well, there have been a number of ideas of how we do that, but we look at AP spread, the line through the most anterior implant to a line distal of the 2 most distal implants, and we measure that. And that proposed by Mish was, if we had 5 implants, we would go 2.5 times. Then there's the English rule that suggested that if we have only 4 implants, we go 1.5 times that AP spread. So the more distal the implants, the less the cantilever length that we're going to do. So is there a way that we can do something with that? And so we ask ourselves, can we change this AP spread within reason? Yes, we can. Simply, I ask my surgeon, give me implants distal to the mental foramen. Well, Jimmy, I can't do that. I don't have enough bone. And so what's going on back there in the mandible, the mandibular canal, the mental loop, in the maxillary sinus? Now, we've seen a lot of outstanding grafting presentations, and no doubt in today's world, there are a lot of grafting that can be able to do this, to accommodate this. But is it possible that we could do something without doing that part of it? And so if we can place those implants posterior, it's going to increase the AP spread, decrease the cantilever, and increase the distribution of forces on those implants. That's going to give us a much more stable situation. And so then we ask ourselves again, can we change this? And the answer is yes, by using tilted implants. And so the tilted implants, if we can do that and not do additional grafting, then it's going to save the patient some money. It will reduce the need for crestal bone grafts. It will decrease the cantilevers in the prosthesis, and in the maxillary could eliminate the need for sinus lifts. Now, the surgeon, Dr. Dalton Keith, periodontist in Charleston that I've worked with forever, the first case we did like this, I had trouble convincing him that we were going to do tilted implants, because he said for 20 years I've been beating him up because all the implants weren't parallel for me. And I said, well, Dalton, it's a new day. We're going to do something a little different. And it is different, but we're still trying to achieve that goal of that hybrid prosthesis. And so it will help us with the load distribution, the AP spread, implant bone contact. We can use longer implants. The tilted implants will provide for graftless surgery and not necessarily flapless surgery if you're doing some flapless things. Our goal is to eliminate the grafting. And so which patients then will benefit from those tilted implants, those group of patients that we saw? They're those patients. A patient who has lost their teeth would benefit. A patient who is going to lose their teeth certainly can benefit from it. A patient who does not want to have any additional surgery, is not interested in or consenting to sinus grafts or crestal bone grafts. The patient who says, I would like to have something immediate, something fixed as fast as I can get that. The patient who has financial concerns. The patient who is looking for simple treatment. So by tilting these implants, maybe we can help that particular group of patients out that would like to have that treatment. So we have to then, if we're going to do that, what are considerations for the treatment planning process? Well, first, we want to get rid of any pathology, but when we start to look at it, we need to look at available space, anatomy and anatomical structures, amount and quality of bone available, ridge relationship, type of planned restoration, and the patient's medical and dental history. Those are things that we have to know and work with. And so there's a very simple way to come up with space and ridge relationship. Here's a patient who wearing a lower denture, wants something fixed. So I bring him in, and I simply take his denture, I make a bite registration, then I take that denture, I put some bite registration material or impression material in it, put a couple of paper clips in there. I can go ahead and then mount it on the articulator, remove the denture, and now I can measure my space and look at my ridge relationship. I can then duplicate that denture for my CT scan and my surgical guide. And so the denture now is duplicated in the denture duplicator. With ortho resin, we take it out. I will then put markers in that denture where I would like to have those implants, at least the platform of the implant placed, so I can place my screws. We'll then get our CT scan, and then we can look at it with the programming. Can we achieve where I would like to have the retaining screws and the spread of the prosthesis? And so now we see the tilted implants. We can look at the amount of available bone. Can the surgeons do that for us? Then I will take that radiographic template, cut a groove out in it, and turn that into the surgical guide. Because this surgical guide, I want the implants within the confines of that groove. I don't need them in any particular spot in there. So we have flexibility to be able to make that work. So then we come back. Can we change the AP spread? And we can, if we can tilt these and avoid those anatomical structures and work within those guidelines that we have set up. Now, another important criteria here with the hybrid prosthesis is 14 to 15 millimeters of vertical space. As a restorative doctor, I know the heartache of not having that space in there. Small amount of space is broken acrylic, broken teeth, and problems to have to deal with. And so that 15 millimeters is very critical for us. And so our surgeons, I want to give the surgeon the directions of what I need to achieve with that. If I give you the surgical guide, and if we discuss that, can you achieve that for me? That's my obligation. I can't expect to send it to the surgeon and then not be happy with the surgeon when I don't get what I need. So I want to do that for them. And so here's a patient that we're looking at. We know we need more space. And so the surgeon now is making some notches in the bone. They'll identify the amount of space that we need in there. Then, with those notches sitting, they will then remove the bone, smooth the platform of bone. We want it nice and smooth and level all the way around. It makes it wider. Once that is done, then that surgical guide can be slipped in. We can identify where to put the osteotomies. Now, what we're going to do, and this is a different patient here, but it's a good showing, if we put the vertical implant, it would need to be about there to avoid that anterior loop. If we tilt it, then we can tilt it back over the mental foramen, gain some space, and be able to distalize actually the top of the implant. And so what do we gain by doing that? Just as we've said, we spread it out, we get better anchorage. And what can we expect? Well, studies have shown that the average in the mandible is about 6.5 millimeters. It may range from 3 to 12, depending on the amount of bone over that mental foramen. And so we'll now come back and look at, can we do this? And again, our literature says there is not a negative effect by doing that. Schematically, here is the implant placed. If it's tilted, we will need to use angled abutments. Angled abutments being used for the two distal ones, straight abutments for the anterior. The implants are placed. The surgeons I work with, they try to achieve 35 Newton centimeters or higher for that immediate load. Those are the numbers that we use, 35 or higher. Then we will come back and place our abutments, torque those abutments to the appropriate torque value, and now the tissue will be repositioned. I will then take that patient's denture and convert that denture into the immediate provisional restoration that that patient will now wear home that day of the surgery. And that's the result that we will have on day of surgery. We'll get an x-ray. Everything looks good. We've achieved what we wanted to. And the patient is successful with it. Does the literature bear that out for us? It does in numerous articles. Here was one recently published. The all-on-4 has been shown to be successful. And at the bottom, use of tilted implants allow for less surgery, immediate load, and high success rate. So let's look back at the patient now that we did the CT scan on, and we'll go through the surgery, and then I'll quickly go through the conversion process. Here's the patient. Step 1, we record the vertical dimension of occlusion with his dentures in, because the dentures are acceptable. There's his surgical guide converted after the CT scan. Tissue is flat, bone is exposed. Our surgeons then will begin to plasty, flatten the bone out for us. We'll then use the surgical guide, place it, make the initial osteotomies, locate the mental foramen, do the posterior tilted implants. Go ahead and place the tilted ones first using the longest implant that we can get in, and then come to the anterior, place those, looking for that 35 Newton centimeters of torque. And it's important to clear the bone out around from that implant so that the abutment can be placed. Anterior implants are now placed. They line up very nicely. Everything is in place. The abutments are now placed. They're torqued to 30. Now, once I have those in place, now I'm going to start the process of the denture conversion. It can be done direct or indirect. Direct in the patient's mouth, indirect if we make an impression. I like to do it indirect on the mandible, but certainly can do it direct. So step 1 is to take that denture the patient was wearing, the original bite we made, close that patient into the vertical and centric that we pre-recorded his vertical. Then we'll take that out. I'll remove those healing caps. I'll place the transfers on the implants, snap an impression. Then I'll go to the laboratory, attach my replicas, my abutment replicas, place those in the impression, go ahead and pour a cast. Now, once I've got that, I'll take it out. Then I use that denture with that bite material to mount that cast on my articulator. Takes about 10 to 15 minutes to get this done till I'm ready to go. Then I'll use that bite. I'll mark it. I'll drill holes in the denture. We'll use the temporary copings, attach those to the cast that's mounted on the articulator. Go ahead and drill holes in that denture, confirm that it fits, place some lubricant on the cast, and I like to place cotton in the access holes to keep any acrylic from getting in there. I will also apply a little bit of acrylic to those copings, and then mix up the rest of it. Go ahead, put that in my denture, reposition the denture, close the articulator in with the bite record, holding the denture in place tightly against the bite record. The articulator is going to close to the pre-recorded vertical. We'll let the acrylic set up. We then take it out. I'll fill in any areas, any voids that I may have to deal with. We'll go ahead and do that. Then I polish that denture, fill in any voids, get it polished, and then go back to the patient, and we're going to place it in the patient's mouth. Takes me about an hour and a half to an hour, 45 minutes to do this if all goes well. I did recently have a little catastrophic event in which I took my knee off of the handpiece pedal in the laboratory. The pedal didn't stop turning. The burr was stuck in the denture, broke the denture in about 6 places. I had to remain calm, put it back together, and then move forward. But about an hour and a half, hour 45 minutes to do this conversion. And it is the indirect method. Now, if you do it direct, and I like to do the maxillary direct because I have the palate to hold that denture into place. On the mandible, I find that if we've taken out teeth and if we've taken out bone or if we've taken out a good bit of bone, difficult to hold it to get that patient into the correct vertical and hold it while material is setting. Now, I mentioned using methyl methacrylate here. There's certainly the bisacril materials. ERA pickup material works for this also if you like to use that, and it sets a little bit faster. I do find that it's a little bit brittle, a little more subject to break, but either of those will work. Now, we'll do an occlusal adjustment so that we don't have any deep cusp-fossa relationship. We want the patient to be able to move around freely. We're then going to close those access holes, and I've started using this matrix tape with one of the temporary materials. Works well. The patient's instructions will be then, do not eat anything that you cannot easily cut with your fork. Well-cooked vegetables, chicken, fish, something like that. But the patient must understand that you cannot eat anything hard. It has to be something easily cut with a fork. And in the provisional, we do not do a cantilever on the provisional for two reasons. The acrylic's not strong enough, plus it puts stress on the implants. And so this patient now at 4 months post-op, everything is healed nicely. We've been watching this. Patient's not doing the greatest job keeping it clean, but we'll work on that. So at 4 months, everything is integrated nicely, nice bone level around the implants. We've checked them, they're healthy. So we're ready now to go to the final prosthesis. And so once we've confirmed going to the final prosthesis, we will start the process and follow the normal steps of making an impression, the records to try and everything that needs to be done to achieve that. And so what I've done here is skip those steps. We're now at the metal try-in phase, and this is a titanium milled bar. And you want to be sure you have an accurate impression by using a verification jig prior to milling the bar. Because they're costly and you don't want to have to redo them. And so I've done an aesthetic try-in to confirm tooth position. I have the lab put just a few teeth on that bar and send it back to me. So when I try the bar, I reconfirm my occlusal parameters. And we'll try everything in with the patient, confirm it's a nice passive fit. Then we're ready to send it back to the laboratory to be processed. Now, on a hybrid prosthesis, you do not want to have any ridge lap. You want that tissue side to be all convex so that you don't have any food traps under there and the patient can keep it clean. And so we've got it back now from the laboratory. I'll check it on the model. I'll take it off. Then we'll go ahead and deliver it to the patient, being sure everything is fit. Check the occlusion with denture. I want a balancing side contact with dentures on if it was a fixed, or natural, or restored upper. Then I would use only the working side, but with the denture, I want the balancing side contact. I want to get everything closed up. Those small screws are torqued to 20. We'll get an x-ray to confirm the fit. Then I'll go ahead and close those access screws. Now, my patient instructions is initially to use mouthwash to brush that denture to keep it clean. And I'll take a little toothbrush and I'll bend the handle for the patient. And sometimes I'll hold the patient's hand up there and have the patient feel, can you feel that's on the tissue behind it? And I'll make a little show and say, well, let me need to bend it a little bit more, and I'll heat it and bend it a little more for the patient. And they feel like they've got something special to take care of it. And so here he is before we started his treatment and after the treatment, and he's a very, very happy man with it. And these patients will be happy with this when we do it. I just wanted to mention about a patient with a failing dentition. Can we treat these patients successfully when they have a failing dentition? And certainly, our previous speaker talked about maintaining teeth, and I do believe in maintaining teeth as much as possible. This fellow had had numerous periodontal surgeries, and things were just going downhill for him. And so we talked to him about what he might want to do, gave him his options. We talked about it. He took about 6 months deciding what to do. And so we did the mandibular arch first. He was pleased with that. We came back, and then we did the maxillary. And so we've gotten a nice result with it. Now, on the occlusion, in this particular occlusion here, when we see this, he's going into a working side occlusion with a group function, no balancing side contact. And one of the things I think is important on occlusion, when they slide and they go canine to canine, and then they go over in that crossover position, I like to have that smooth transition back from the centrals back to the canine and the posterior teeth so that they aren't locking in, because there is some concern about breakage on this and patient putting a lot of forces on there. And so a smooth transition. The other first line of defense is to put these patients into a bite guard and get those patients to wear those bite guards at night. That will also help, especially a patient who maybe break a tooth and will come back and will do that. And so we want to be sure that we manage in the occlusion for them. And so we ultimately get a very nice result for this gentleman. He's very happy with it, and so we'll just follow him along. And so now, with that, we look back. Did we achieve what we said we were going to do? Well, our patient needed some dental treatment. They wanted something immediately. They didn't want to have a lot of surgery. I believe it's predictable. It certainly has proved to be predictable, and we have a good scientific base here for what we're looking at in our literature. And so one more article to look at. This was a very, very well-written article, and it was looked at, and it was determined that the all-on-4 implant-supported distal cantilever prosthesis had a very high success rate, both implant and prosthetics. It was also recognized that doing the tilting and the cantilever did not interfere with the technical prosthesis part of it or the health of the implant. So we have now good evidence that this tilting. Now, it is important to emphasize again, when you're using tilted implants, they must be splinted. You don't want to do this and then use single units. The criteria here is that splinting and splinting around the arch. You have any three implants forming a triangle. Triangles cross each other. Engineers build tall buildings and big bridges by building triangles into their structures, and that's what we're doing here. Now, you may see some of these patients, especially on this mandible, with some inferior hygiene. You get calculus on the lingual of the lower. It's been speculated, maybe because that's where the duct opens and we've dropped it down, maybe patient hygiene, but you sometime will have a little bit of a hygiene issue down in that area and have to work with the patient. And so there may be some change in the hygiene. It's a matter of bringing that patient in, training them, working with them, and hygiene recall has to be based on patient needs. There are some patients, I have one patient that we've seen for many, many years. She probably doesn't need to see hygiene but once every 2 years. I have another patient, every 3 months he's building calculus on there. So I think it's got to be an individual recall program that best suits that patient. And so with these, resin veneering has the advantage of ease of repair and modification. It does have the disadvantage of having some discoloration. And I thank you.